Good afternoon, everyone, and thank you so much for joining. Thank you, Courtney, for the introduction, and also Courtney's been instrumental in organizing this. Thank you, David Cato and Sierra Tucson, for the presentation. And I also wanted to give a quick shout out to the Cleveland Clinic here in the area I work for making the request for this trauma presentation, and for also allowing Sierra Tucson to open it up to other behavioral health providers. So I wanted to share that with you, and thank you again. So for those of you that don't know me, my name's Stephanie Burkle. I'm a treatment placement specialist with Acadia Healthcare, the world's largest behavioral health company. We've got a team all across the United States. I specifically work in Western PA, Northeast Ohio, and Western New York with behavioral health professionals and individuals when someone's seeking a higher level of care. This could be a higher level of care for anything mood, mental health, depression, anxiety, substance abuse disorders, trauma and post-traumatic stress, and any other co-occurring disorders. So we're here to help you out. You can find your local treatment placement specialist contact at www.treatmentplacementspecialist.com, and there's a map as well as all the services we provide. But we can really save behavioral health care workers time when looking for different higher levels of care, including what insurance works where, what their diagnosis and appropriate level of care might be, and where the just best possible placement for an individual is. So I encourage you to reach out to your local treatment placement specialist and start to work with them if you haven't already. Sierra Tucson is Acadia Healthcare's flagship facility out in Tucson, Arizona. Just absolutely beautiful. In the past 4 years, I've been out there at least 4 to 5 times and always have a wonderful, wonderful experience. Their clinical team is top-notch, and it's one of the best facilities in the country, if not the world. And David Cato will be presenting today. I have the pleasure of announcing that he was most recently promoted to clinical director at Sierra Tucson, and he's been there since 2008. So again, thank you so much for all attending, and thank you, David Cato, for the presentation. And for that, I turn it over to you.
Thank you so much, Stephanie, and thank you also, Courtney, for helping me with the media piece of these things and also helping set up this event, at least on my end. The treatment placement specialists are a very important part of Acadia Healthcare because they're the ones that link all of us to you, the participants at this presentation, and so I'm really grateful for them. So thank you again, Stephanie. What I'm going to talk to you about today is the presentation is titled Trauma, Attachment, and Recovery, and we're going to talk about that and also things that are in between that. And I'm going to be able to give you some definitions of what trauma is, some different examples, the different kinds of attachment styles that people have, and also how we start to work on and heal trauma and heal attachment wounds. And so one of the things that we'll be doing, at least a couple different things that we'll be doing, is some experiential exercises. There's a few things that I want to do throughout this presentation that can help us feel grounded and get connected with our surroundings and be able to feel a sense of connectedness and safety, and also help strengthen our attachment relationships with others. You might notice during this presentation I might be looking over in this direction, and that's just because there's like 2 screens here, and this other screen has the video so that I can see that I'm, centered and looking like I'm supposed to here. And so it's not because I'm distracted, even though I might be sometimes. I'm just looking at the video to make sure that I look as I should for you all. The first thing I want to talk about is something called orientation. And so my education and training is as a somatic experiencing practitioner. And so we work a lot with the nervous system and helping the body heal through wounds that the body has experienced. And those things basically can present as emotional issues as well. I picked this image mostly because I really like the aurora borealis, but it gives us an opportunity to be able to see something that looks pleasing. It could be aesthetically pleasing or just something that feels good to see. You might not even want to look at this, or it might be too clashing of colors. But if maybe you're in your home environment, or maybe you're at work right now, and maybe you have a view outside your window, or maybe there's something in the room that you're in that always draws your attention in a positive way, what we can do is we can bring ourselves to connect to our environment through our senses. And so we can do it by vision, we can do it by hearing what's going on, We can also notice by a sense of touch. You can't see, but I'm feeling the texture of the desk. That can help us get grounded. And then there's also, we can orient by taste, tasting some really good food, and also by smell. And so we use our senses to be able to connect to our environment. And one of the simplest and easiest ways to do this is through vision. And it helps us to connect to our surroundings because it's always readily available to us. We have the control of being able to look around and see our surroundings. And so if you would be open to taking a moment, of course, anything that I suggest, you're definitely, there will be no judgment if you decide not to do it. In fact, I can't see you, so I wouldn't even know if you did it or not. But if you'd like to join me in this exercise of orientation, it will allow us to allow our system to start to settle. So basically what happens is people who have experienced trauma or attachment wounds, they get feelings of not feeling safe. There's these things that could happen in the body. It might feel like anxiety. It might feel like depression. It might feel like anger. But these unsettled feelings can attribute to that sense of not being safe. And so orientation or orienting to our environment can help us start to get reconnected in our body and see that we are safe. What that feeling inside, that threat response inside the nervous system, is as a result of traumas that people have experienced. And so because your history is connected to these traumas that you've had, you might feel like you are still in a threat response, or you might feel like the danger is still there even though something happened 20 years ago. And this also may be occurring with your clients. You probably see this a lot, of somebody feeling like they're scared of something that doesn't really make sense to be scared of because it's not an immediate threat, but yet to their nervous system, they feel like it's that threat, and they feel like it's not going to be good for them to not find a maladaptive way to cope. And so if you'd be welcome to join this exercise with me to allow your eyes to go wherever they would like to go around the room. And that's an invitation. And so instead of saying, hey, look to the left, or hey, look to the right, it's giving your body the absolute power and control to be able to look wherever it wants to. And so take a moment and just do that, and I'll do it with you. At this moment, I ask you to go inside your body and see what happens. Maybe you were feeling a little stressed prior to this and were able to get some sense of settling after that. Maybe perhaps you were really relaxed and looking around actually made you realize that you weren't as present as you needed to be, and now maybe you're more alert. And so everyone's response to this can be different, and that's okay. The goal is to be able to provide that sense of connectivity and be able to have a sense of settling within the nervous system. And I hope that that's what some of you had been able to experience with it, for those of you who decided to do that with me. You can also do this anytime, anywhere. It's really helpful to be able to connect to that and not only allow yourself to connect to your environment by looking around, but also to check inside your body and see what you might notice that feels good at that moment. Some people who have chronic pain or who have issues with parts of their body might have negative feelings inside about that. And for people who are doing this kind of work, you can allow yourself to find something that feels soothing externally and then see what can be soothing internally, or what is feeling more soothed internally. Thank you for participating in that with me. There are a lot of different definitions for trauma, and one of the first definitions that I talk about it's pretty ancient. I know it's Sigmund Freud, and yet the reason I use this is because it gives us the idea that we knew this, at least some of this, that long ago when Freud was practicing. Freud says trauma is a breach in the protective barrier against stimulation, leading to feelings of helplessness. And so what this means is that all of us have our bubble or our space. It might be really far out, it might be really close in, but we know that somebody should not be in that space. We don't welcome everyone into that into that bubble of ours. But there are the people that we do. If I have this bubble and somebody steps into my space and I do not want them there, that is considered a breach in my protective barrier. And so I'm going to do one of several things to counteract that. I'm either going to push that person away, or I'm going to step back from that person, or maybe I'm going to do nothing. And so those responses, we're going to talk a little more about them later, are fight, flight, and freeze responses of how our nervous system helps to take care of itself. They're self-protective responses that allows our system to be able to take care of that threat, the threat that we might be perceiving it's something from a long time ago. If I'm at the grocery store and I'm in line and there's somebody who's like this close to me, and right now with COVID, it's really something to be aware of, and how we all need to be paying attention to our space, and not everyone is doing that. So if somebody is this close to me and I have the impulse to, I don't know, maybe like put my elbow back a little bit to move them back, or maybe I'm going to kick my foot backwards or something. Of course, we don't do those things because that's not socially appropriate. But we have that impulse inside that says that this is how I would protect myself right now. So what we do instead is we can either ask the person, hey, will you step back a little bit? Or we might move forward in order to get away from them. And so it's a way for us to take care of our protective barrier when there could be a possible breach of that. Dr. Peter Levine, who's the founder and creator of somatic experiencing, says trauma is in the nervous system, not in the event. And what he means by this is kind of what I was talking about earlier in regards to we can experience a trauma that happens 20, 30, 50 years ago, and yet it's still active. That stress response, that threat response and stress response is still active in our bodies. That just trauma is still happening. And so I might feel like I'm living in that moment over and over and over again because I never got to fully process it, or I never got to find my safety after that event occurred. Dr. Robert Scare says meaning and helplessness play a role in how an event becomes a trauma. This one is important because we can have these things that happen to us and our responses to what happened to them, but the story we tell ourselves about it is what's really important. So let's say, for example, and I get this a lot when I'm working with families here at Sierra Tucson, is the parents of a child who's struggling with substance use or mood disorder or trauma, the parents will say, oh yeah, they said that they have this trauma, and that's not what happened. They remember it incorrectly. But that person who experienced it remembers it exactly the way that they did, and whether or not it is what happened, that's the meaning that they make out of it. It's the story they tell themselves about what happened. And so if you tell somebody for years that, oh, that's not what happened, that's not the correct story, that person is going to be invalidated, and it's going to exacerbate that trauma symptom. And so being able to, even if you don't agree, or even if you know that what they're saying is not true, being able to still support them and validate their experience is what's going to be important, because we want to be able to help them feel safe and connected as opposed to denied or invalidated. And so when we look at the whole experience of the personal bubble and what happens inside, and then also externally and what happens in my mind about the meaning, that's kind of the full circle of what how trauma can impact. So throughout this presentation, I do have images kind of strewn about, and this is an opportunity to practice orientation. And so I'm going to be inviting you, when we come across some of these pictures, to see what you're feeling, see what it looks like. And again, any of the pictures, if I show them to you and you're like, ooh, I don't like that, that's totally okay. What we do is, if you want to look externally, that's fine. I actually had done a presentation with this slide in it before, and one of the people in the crowd had said, oh, I don't like tulips. I really don't like them. They make me sick to my stomach. And that is something that might happen, and that's okay. We're not judging or saying that we should or should not feel a certain way about something. It's just a way of orienting. And sometimes orienting is to orient to something that's not pleasurable, even though we do want to find more pleasure in things. And so I just want to take another moment to give you the opportunity to orient to either this image that I presented, or you can even look around the space of your room or house or wherever you are currently, and find something that brings you a sense of comfort. And then I also ask again to have you go inside and see what that feels like. See if you're noticing any kind of rise in stress or decrease in stress, or if something feels good or something feels worse as you're doing this. And throughout this presentation, we're going to track those pieces and see what they're going to feel like. So trauma, as I had said, can be a lot of different things. They're uncontrolled events, so we don't really plan on them or ask for them to happen, obviously. I gave you definitions of some of the professionals for trauma, but the best definition that I've heard was from a somatic experiencing presenter by the name of Russell Jones, who practices out of Brazil. He said that trauma is anything that happens too much too quickly. So if too much is happening of things that we cannot handle in too short of a time, it's going to overwhelm us. And when it overwhelms us, it overwhelms our nervous system, and therefore wounds can be created. And so this can look like a lot of different things, and I'll be going over some of the examples of trauma next. But to break it down a little bit is anytime someone experiences something traumatic, there's a big induced feeling. It could be something like terror, shame, rage, panic. So anything really big that comes up is usually triggered by some kind of traumatic event that happens to someone. It could be a mild event, it could be a severe event, and we all kind of respond to those events differently. But if someone is feeling a huge feeling like that, it's most likely the result of trauma. There's the high intensity events, big T traumas, or low intensity events, little t traumas. And so I don't want to invalidate anyone by saying something may be a little t or a big T, but what I will say is that everyone experiences things in a different way. And so what might be a little trauma to some people is a big trauma to others. And also people can experience a lot of different little traumas that would evolve into a big trauma. And so to be able to break that down a little bit, I'm going to go over what some of those could look like coming up next. But I would like to just say that I validate all the experiences. And I once was working with a resident who told me that she felt invalidated when I used the phrase little t to talk about trauma. And I validated her back and just let her know that, yes, her connection of that and her feeling that little t, saying little t was triggering, that's okay. And I vowed not to use that term around her anymore. And so we kind of meet our clients where they're at. There's a lot of different types of trauma I'm going to talk about, the first of which is single incident trauma. And this is usually like one trauma that happens, considered it a big T, some of which are little t's, but these are things that could happen. And examples are an accident, and this could be like a car accident where, let's say, for example, it's not just a fender bender, but the person who's in the car accident actually crashes the car is totaled, and they end up hospitalized, that kind of accident. There's natural disasters, and you might be thinking, well, the natural disaster is pretty massive, and that does a lot more than just a one-time thing, and yes, that's absolutely true. The natural disaster itself is a single incident, and then it's all the devastation afterwards that becomes the complex trauma, which we'll be talking about next. A single abuse or assault is a single incident trauma, and this can happen, or this mostly happens with people who are non-relational component. So people who you don't know, like a random mugging in the middle of the night on the street, somebody takes your wallet or someone takes your purse or bag, and you don't know that person, that's considered a non-relational single assault. Traumas become more complex when it's a relational trauma. Having a sudden loss, or actually any kind of loss, can be a single incident trauma. Sometimes what I've noticed is people will have lots of losses over the course of an extended period of time, and it's not until they have that third or fourth or fifth loss that all of the feelings start coming in about all of the other losses. And so that can be considered single incident trauma, but really any kind of loss, not just sudden losses. Witnessing violence, and this could also be witnessing violence in the media, not just witnessing violence in person. This could be single incident, and this also could evolve into complex depending on what kind of thing was happening. I think of the September 11th attacks in 2001, and I think of seeing over and over again on the screen what was happening and just having that memory come back, even though I wasn't there and I didn't know anyone that was there when it happened. It's like having that feeling. So that single incident trauma can actually turn into something more lifelong. And then having an illness or chronic medical issue. This would be, for example, people who have chronic pain or something like Crohn's disease or fibromyalgia. They might actually be afraid to go out or go socialize because of their illness keeping them at home, and not really knowing when the next flare-up is going to happen. And so with these single incident traumas, and there's a lot more kinds of single incident traumas than just these, and I'm sure you can come up with some of your own. But these single incident traumas are definitely something that can kind of kickstart what complex trauma could turn into, or what developmental trauma could turn into, which is what we're going to be talking about next. In this image, I invite you to see what you think is happening here. As I've shown this to some people, I get a lot of responses, and the first response is that real? Is that guy photoshopped, or is he actually there? The answer is, I don't know what the answer is. And yet, even so, seeing something like this can be terrifying. And usually when I speak to an audience, I ask the crowd, have you ever seen a tornado before? Have you ever been in a tornado? Did you grow up in an area where they had tornadoes, or do you still live in an area where they had tornadoes? And I ask this because it can show us, or at least for me, the way I help explain the difference between something that is traumatic versus something that's not. I grew up in Northeast Texas, where it's considered Tornado Alley. We actually have a tornado season there that goes from like April to June, and during that time frame, there are an increased number of tornadoes. And so we would have tornado watches and tornado warnings, and I remember doing tornado drills in grade school growing up, and we had a tornado siren in our hometown that they test every month. And so I was never in a tornado, but what my nervous system was trained to do was to recognize that tornadoes were a threat to me. They were something that could harm me and hurt me. And so what I learned was not in a traumatic way, but that I should be afraid of a natural disaster such as a tornado, because it's a real threat that could harm me or someone else. And so I do not have trauma around that, but when I see, like, for example, this picture, or when I see things such as tornadoes in the news, I kind of get that feeling of, ooh, that's scary, but it's not something that traumatizes me, or it's not something I hold on to. And so I invite you to ask yourself kind of what you notice when you see this. Maybe you've had some experiences with natural disaster, or a tornado specifically, or maybe you know people who have lost things through natural disasters, whether it's loss of loved ones or loss of property. A lot of people lost a lot during Hurricane Katrina and Hurricane Sandy, and so we see these things and we know that they're a really big deal, and we get conditioned to be afraid of them, reasonably so. And so we watch out for warnings, except for the guy in the picture, because for whatever reason he thinks it's a good idea to do that. And there actually are people like him who are chasers, tornado chasers. And I know there was a movie back in the day called Twister, I believe it was. I think it was the early 90s. But a movie about people who actually chased after tornadoes, and people actually do that. And it's something that's exciting and thrill-seeking for them. And that's not something that I would ever do. And I'm not sure if any of you would, but sometimes when people see these images, they're like, oh, that looks so cool. I want to get closer. I want to take pictures of it. And so anything that you feel on that spectrum is totally okay. The next type of trauma I want to talk about is complex trauma. The way I think of complex trauma is single incident trauma is like one big T that can happen. A complex trauma is like a big T and more big T's and little T's kind of all happening at once. There's really a lot going on when we're looking at complex trauma. These are also likely to be relational, such as ongoing abuse or neglect. If you're being abused or neglected by someone, it's usually somebody that you know very well. It could be a parent or a partner or a friend or even a teacher or a boss or employer. And so you might be noticing that feeling of the ongoing abuse, like what's going to happen next, when's the next shoe going to drop. That's a kind of complex trauma. Relational meaning that it's connected to people. Domestic or community violence. Currently, there is a lot of community violence out there, at least the year of 2020 has brought that. Also domestic violence in the home and other types of community violence, such as being bullied or gang violence, etc. People who have experienced war in any type of way, and this is such a broad spectrum because it can be people who are veterans, people who are loved ones of veterans, or people who are survivors of such wars. And so this kind of piece can create a lot of things that stack on top of each other that create this complexity. When I first started learning about trauma healing, when I first started learning about becoming a therapist, that was when I thought that PTSD was just about war veterans. And then as I started to become a trauma therapist, I was like, oh, actually, trauma is more than just that. PTSD and trauma are different, which I'm going to talk about as well. There's also ongoing coercion or betrayal, being trapped emotionally or physically. A lot of times people in relationships, especially abusive relationships, might feel like they can't leave the relationship, but yet they have the good moments and the not good moments that kind of both happen, and so they get trapped in that. And so people might say to them, well, why don't you just leave if they're doing that to you? Well, the complexity of trauma doesn't necessarily allow someone to have that kind of insight. Like they may see that that's what's happening, but their nervous system is saying, no, I feel safe with this person at times, and that's better than not feeling safe at all with being by myself or being with another person. Having recurrent physical or sexual abuse. Any time of physical or sexual abuse is going to be complex trauma, also usually because these are relational as well. And then experiencing abandonment, whether it's an abandonment from when you were a child, or maybe it's abandonment from a relationship, or maybe it's an abandonment of friendships. People who lose friends like suddenly can feel abandoned. And so abandonment can also really be a big complex trauma as well. Developmental trauma is the next piece I'd like to discuss, in that there's always complex trauma within developmental trauma. And when people think of developmental trauma, they may think most usually about childhood trauma, which yes, that is true. And also people who are experiencing that childhood trauma, that can go all the way up through age 25 for when the prefrontal cortex is still developing. And so as our bodies continue to develop, we might experience something in our late teens or early 20s that can still be considered a developmental type of trauma. It occurs within the caregiving system much of the time. Developmental trauma is also relational trauma. And so these are traumas that have happened to us in relation to a relationship that we've had with someone, whether it be our parents, our spouse, etc., or even our children. It interferes with healthy attachment and development. And so if I'm having unhealthy relationships, or if I only know unhealthy relationships from my childhood, I'm only going to have unhealthy relationships because I don't know how to create a healthy relationship. I was actually speaking at a resort, Canyon Ranch, last week, and I was talking about some of this information, and someone actually had said that they feel like their trauma and their partner's trauma kind of feel connected, and that it actually makes their relationship stronger. And there's something called trauma bonding. And so people who have experienced trauma or have severe PTSD can bond together because of their severe trauma, and they can actually heal some of those attachment wounds in that way. Having chronic relationship problems, not being able to have healthy relationships or scaring people away. This can also, developmental trauma also usually looks like, people who have severe developmental trauma usually looks like what people would refer to as personality disorders. We at Sierra Tucson call them maladaptive personality traits or maladaptive coping patterns, because people who experience symptoms such as what borderline personality disorder looks like, those people have learned to adapt to horrible things that have happened to them, and those behaviors are how they get their needs met. And so maybe looking at them in a different light and saying, this is somebody who's really struggling and their behaviors are really out of control, and I want to be able to help them change their behaviors, instead of, oh, you're just being borderline, or, oh, that's a borderline attitude, et cetera, et cetera. So we want to be able to be not as shaming and not be able to tell them they're bad in that way, but to be able to meet them where they're at and try to provide the skills to help them move forward. And then also developmental trauma typically yields some kind of shame. Intergenerational trauma, also known as transgenerational trauma, is trauma that's handed over or down over generations. And so there's a lot of different examples of this, and I'm going to go over a few of them. The first is for people who were survivors of the Holocaust. They are doing research now where they are finding that people who were not even alive at the time of the Holocaust, their grandparents, great-grandparents, etc., were there, and they survived, fortunately. What they're finding is these people who are not even alive yet are experiencing symptoms as if they were in the internment camps. And so they're being handed down these symptoms over generations, not intentionally, of course, but in order to help kind of adapt, because their parents exuded those behaviors, and so that's what they learn over time. I once was speaking with somebody here who grew up in Mexico, and when she moved to America as a teenager, she would be speaking Spanish in a grocery store, and her mother would tell her not to do that because people would judge them. And so at a young age, this person found that their race was something to be shameful for, because, or not necessarily their race, but their culture was to be shamed for, because they were told by their mother, hey, don't speak in Spanish in public or people are going to think something negative of you. There's also, I also had someone who, it was a young Black gentleman who was here in treatment, and we were talking about transgenerational trauma, and what he had said when we were talking about this is that when he was about 5 years old, he would be in the grocery store with his mom, and his mom would say, hey, get your hands out of your pocket or people are going to think you're stealing, just because of the color of his skin. And so he grew up thinking that being Black was bad, not because his mom made him feel bad about it. She was trying to protect him. But these messages that we get over these certain kinds of things that happen say, I'm a bad person, or there's something wrong with me because of how I've been taught to, or what I've been told to do in order to take care of myself. Because that generational piece, his mom was traumatized, I'm sure in some way, or her mother or parents were traumatized, and it's handed down over time. And so being able to do the work and break that cycle is something that can be difficult. But also recognizing that right now in this year, what's been going on is a lot of that intergenerational things being passed down, whether it's intergenerational shame about things, or intergenerational rage, or intergenerational racism. And then, of course, people who've experienced any type of war, people who are veterans, people who are first responders, them handing down those symptoms to their loved ones who they're very close to. I've worked with a lot of people who've had fathers who were Army sergeants, and the way they behave like they're Army sergeants too, and that's kind of how they were raised. And so not necessarily calling it trauma, but it's just kind of that piece of maybe they were shamed when they were young, and maybe they are holding on to these negative ideals of themselves. Before we move to attachment styles, another type of trauma I wanted to discuss briefly is secondary trauma. And as we're talking about the big primary traumas, secondary trauma is big, especially when we're looking at things such as the intergenerational trauma piece, because there can be those little things that happen over time that build up. Like there's something called microaggressions that can be directed at people who are LGBT, or directed at people who are minorities or people of color. And there's a lot of different things that people say and do to harm other people, and a lot of it nowadays is not really intentional. It's things that are said in ignorance, and so those microaggressions can come up, and experiencing those can be secondary trauma. There's also other pieces of secondary trauma across intergenerations, and one of the things that I think of is when, and this never happened to me, but I've heard it happen to others, but when people, maybe a child is scared to walk a couple of blocks to school, or walk a couple of blocks to the bus station to go to school, because there might be a bully who has bullied them either at the bus stop or on the way there, and they say that to their parent or their grandparent, and that person responds with, well, when I was your age, I had to walk this far and this many feet of snow, and never, etc. And so that's a way of invalidating someone's experience, and that person might feel like their experience is nothing because of, say, yeah, you're scared to walk two blocks, and I did way better than you when I was little. And so people get those messages sometimes, and of course the person telling them isn't intentionally shaming them, I'm sure. They're really just kind of saying, hey, toughen up, be a man. And that's another thing that can be considered a secondary trauma, is saying messages that are sexist, or messages that are not geared towards health and safety. So I want to talk a little bit about attachment, because we've been talking about attachment wounds. I want to talk about the attachment styles, and then I want to do an attachment exercise with you all. So the 4 types of attachment styles, as I've learned them, and I am aware that there's so much information out there on attachment now. There's a trainer by the name of Diane Pohl-Heller. I'm not sure if any of you are aware of her, but she is someone who helped develop somatic experiencing with Dr. Peter Levine, and then she kind of branched off and did more attachment-based somatic work. And then she trained someone named Allison Hallquist, who practices outside of Boulder, Colorado. And so Allison and Diane, and also some other trainers, teach this modality called DARE. And DARE has 4 modules, and I've taken the first module. So this is the type of, it's the DARE model that I'm teaching here with these 4 types of attachment styles, and anything else is of course up for discussion, because I know people talk about fawning and these kinds of things, and these are the way that I learned attachment styles, and so this is what I'm going to go off of today. So I'm sure you're probably saying, oh, and what about this one, and what about that one? Yes, absolutely. And we all get that information where it helps us understand, like, this is something that I get, and this is something that helps me, and this is what that is for me, is being able to break down each of these and talk about the wounds and how to heal them. The first type of attachment style I want to talk about is secure. Secure attachment is the relationship style that we all want to have as human beings. We want to have the healthy connectivity. We want to be able to be there and be present with everyone and be able to have good connections. There are times when secure attached relationships will have difficulties, and that is normal and that is healthy. And so it does happen. Anxious attachment style is for the people who really have to be loved or have to be with someone all the time. They're kind of like that separation anxiety type of dog that just has to be with you all the time. And that's an anxious attachment style. The avoidant attachment style is about the opposite, where it's like, I don't want to be in relationships. I don't want to be around anyone. I want to isolate. And then there's also the mixture of the anxious avoidant, where there's the person who wants to be with someone, and then when they don't, and they kind of do this back and forth, and it could turn into a I hate you, don't leave me, or borderline personality type approach to things, and yet it's really just attachment wounds. And so when we talk about borderline personality being more of a trauma response as opposed to an actual condition, that's what I think of as the anxious avoidance attachment person of, I need to get my needs met and then I need to run away when I don't. The next one is the disorganized attachment style, and this is the attachment style where people most likely were in an abusive household where they were not able to really know what to expect. Maybe their parents were alcoholics or struggled with mental health issues. And so with the disorganized attachment style, it creates that chaos. So chaos was given to them at a young age, and so then they carry through chaos and end up in chaotic relationships and end up not really connecting with other people in a healthy way. And so what I like to do when I talk about these is I like to invite the audience, if you'd be willing to do this with me again, to imagine your tribe. And by tribe, I mean who would be there for you if you really needed, if you were in despair, or if you were in the hospital, or if you were just needing a friend or a loved one. When you close your eyes, who do you see? Perhaps it's your mother, maybe a friend, a spouse, could be a therapist or a teacher. Sometimes people do this and they can't see anyone. And so I say, what about a pet? Imagine a dog or even a cat. And how would they present to you in your tribe? And as you're feeling this, see what happens inside as you're putting your tribe together and seeing your tribe. And see how that feels inside. As you assemble your tribe, find one person in your tribe and imagine their eyes. See what it's like to look into their eyes. And I would imagine those eyes are kind. I would hope they're kind. And being able to see what it feels like as you feel the kind eyes. And then as you do this, I want you to notice somewhere inside your body that feels good. Maybe the body feels good all over, but if it's just like a hand or a foot, maybe your leg or even your neck, something that feels good. I know right now because of COVID, it's probably very difficult to imagine being so close to people and having that connection with our loved ones. And so I ask that if you feel comfortable doing so, imagine hugging that person with the kind eyes. Of course, this is post-COVID, so the rules don't apply for social distancing. So just let that person hug you and hug them back and see what that feels like. And then see if you can notice that feeling inside your body. And then at this point, whenever you feel ready, you can let your eyes go around the room. Kind of check out your surroundings again and just kind of notice what happened inside. I don't know about you, but I noticed, like, even as I was guiding that, I noticed kind of my system kind of, came down a little bit. And we're going to talk a little bit about parasympathetic rest or relaxation. And so I really kind of had some parasympathetic resources come in because kind eyes are something that really helps us feel settled. And kind eyes are a reflection of secure attached relationships. Somebody has kind eyes, it doesn't mean that you can't have anxious or avoidant or even disorganized pieces with them, but the kind eyes represent the security, which is where we want to be. Thank you for doing that with me, for those of you who did. And if you didn't, thank you for still being here. take a moment and see what this image looks like to you. I really like red a lot. Red's like my color. And I love how much red is in this, and I just love the contrast. I've noticed that when I show this to people, there's mixed reviews. Some people don't like it. They think the colors clash too much, and it's not something that's pleasing for them, and that's okay. And so I ask you to just recognize or feel inside what that might feel like to you. It might be relaxing. It might not be. But just see what happens. And then I want you to check in with yourself. Ask yourself if there's anything you need right now. Perhaps a drink of water. And whatever it is you need right now, give it to yourself. There are neurological effects of trauma that can really get into a place where it dysregulates us in a big way. So the certain regions of the brain show increased levels of the hormone known as CRF or corticotrophin releasing factor. And I call this the stress hormone for short, just because I don't really want to say corticotrophin releasing factor a lot of times today. Interestingly, almost all drugs of use have been found to increase CRF levels, suggesting a neurobiological connection between stress and drug abuse. And so what happens is people actually think that as they get stressed out, this is their stress increasing, as they get stressed out, they start to notice the stress increasing. And so they feel that stress increasing, and then they'll find maladaptive coping patterns to kind of turn it off or remove it. And so they say, hey, I'm getting really stressed out. I'm going to have some drinks. And so what happens is they actually start to feel like they're feeling better. You may have talked with those people or know about those clients that you've worked with that have said, oh, after a couple beers, I feel normal. Or when I'm high, I feel like myself. And so you hear those things, and that's basically them doing this and then coming down into this, or what they think is that. What's actually happening is they're still increasing. The stress level continues to rise, and they're not able to bring this in even though they feel like they are. And so that gets to a point where they've used so much that they are no longer the functional alcoholic or no longer the functional addict that they've been for so long, because their system's not able to do this. It just keeps rising up. And so they use that to feel like, hey, I'm feeling better, or hey, I'm feeling like myself, when really they get to a place where they can't stop anymore, and that's when they end up in a place like residential treatment. We talk about post-traumatic stress response instead of post-traumatic stress disorder. Post-traumatic stress disorder is a diagnosis that is in the DSM-5 that basically says if you meet, I don't remember how much of the criteria, but if you meet, I think it's 7 out of 5 criteria, or 5 out of 7 criteria, if you meet that, then you can be diagnosed with post-traumatic stress disorder. But what if somebody only has like 2 or 3 of those symptoms? Those symptoms are extreme enough to keep them from going to work or from going to school or from engaging in society. So we call that post-traumatic stress response or trauma, in that not everyone with trauma will be diagnosed with PTSD. PTSD is basically a diagnosis that's underneath the umbrella of trauma. So trauma is here, and then the diagnosis of PTSD is under that umbrella. So the word trauma impacts more people than PTSD does. And people use PTSD as an example of, hey, look at this. I do have this illness, or I do have this issue. And for people who don't have the diagnosis, they can say they have trauma, but how much does that really mean to them? We talked about this a little bit already, but the impact of trauma sometimes appears resolved, and yet the symptoms are repressed. And so the trauma is still in there. That threat response is still there, and your body's saying, hey, I'm in danger, even though that threat is actually gone or has been gone for a long time. Trauma reactions may later be triggered by situations and events. Kind of as I discussed earlier, you have the person who's had 5 losses over the last, let's say maybe 5 or 10 years, and they don't feel the feelings up until the last loss, and then everything comes flooding in, and they grieve all of those losses at the same time. And then recent evidence suggests that even with appropriate interventions following trauma, the person might still develop PTSD. And so what this means is even after natural disasters, people are going to different parts of the country, different parts of the world to do immediate trauma work like EMDR, like somatic experiencing and biofeedback to help people kind of move through these things. And what they have determined or what they are learning is that they're learning that people are still developing PTSD and still having these reactions to these things that have happened, not because of the actual event that happened itself, but because of what can bring PTSD about. And so what are the predictors for developing PTSD? The first is magnitude of exposure. How much trauma has happened and over how long as far as prior trauma, and what does social support look like? And so if somebody doesn't have a healthy support system, they're more likely to develop PTSD because they don't have that resource to lean on. People who have prior trauma or have a high magnitude of exposure, they also are going to have a higher likelihood of developing PTSD. When I do this with people in person, what I ask is, what do you see here? What do you notice within this family? One of the things I've noticed over the years of doing this kind of work, this trauma work and attachment work, what I see is as I present this information to people or this picture even, what I find is that it activates a lot of people. And what I mean by that is people actually see this image and they think, oh, that's not what my family looks like. Or they say things like, that looks like they're faking it. They're not really connected. I've had several people actually say that they look like they're different races. They're not the same race of Asian. And so we hear all of these different examples that people have, and it bounces off of their own experience. When I show this information to residents that are in residential treatment, their response is typically, oh yeah, it looks like they're faking it. It looks like a dentist commercial. It looks like these various different things that they don't connect to the relational piece of it. But when I show it to family members of those loved ones, they say, oh, they look like a happy family. They look so loving. I love how close together they are. I mean, you get to see the difference between somebody who has a lot of, not necessarily a lot of trauma, but attachment issues versus the people who have more secure attachment. And so this picture is really interesting just because of the different kinds of feedback I've gotten about it over the years, and asking a crowd saying, hey, do you see a healthy family or do you not see a healthy family, really elicits a lot of attachment system engagement. And so it could be an unhealthy attachment engagement or a healthy engagement. And so what I ask you is, what do you notice inside as you see this family? Does this family reflect that happiness? Or does this family feel like it's a little more on the fake side? My personal opinion, I think they look like a happy family. And it's okay if you don't. And if it brings back thoughts of, or if it brings up thoughts of your family and how your family was either very loving or very not loving, it's okay to notice that. Nervous system injury or wounding is nervous system dysregulation. So I've talked a little bit about dysregulation, and I'm going to be talking more about it. But basically, when we experience a trauma, it's a wound on our nervous system, which basically means that my nervous system, if I experience a trauma, there's going to be and it's a physical wound that happens to the nervous system. And it's something that can help prevent us from being able to do certain things, or maybe it gets a fight, flight, or freeze response stuck in our system. The autonomic nervous system is connecting everything inside of us. And so our heart rate, if our autonomic nervous system gets activated, or if I get activated, I'm going to recognize my heart rate will increase, my blood pressure increases, I may sweat, I might have digestive issues, and I might even be breathing faster. And then if I'm actually deactivating, or if I'm feeling like I'm calming down, the heart rate will decrease, blood pressure will decrease, the whole body just kind of settles and has more rest and relaxation. The number one job of the nervous system is to ensure survival. It's the first part to start working in utero and the last to shut off if someone is suffocating. It connects the brain to the organs, including liver, heart, and lungs, sweat glands, and the interior muscles of the eyes. So when we are orienting to our surroundings, the interior muscles of our eyes are actually responding to our nervous system and giving it a signal of, hey, this is safe. Hey, there's no danger here. And so your system starts to help relax because you can connect to your environment and see that there's no threat. I've been saying activation or dysregulation, and I've also been saying deactivation. So we have sympathetic arousal of the autonomic nervous system. And so sympathetic arousal means the activation piece. So this is my fight and flight coming on board saying, I'm going to get ready for action. I need to take care of myself, or something's going to happen here. It stimulates the organs and striates the musculature, and that my body is getting ready to do something. And so typically we look at this as my shoulders are back, my shoulder blades are back, and appears more of a confidence piece. That's the fight response, at least. And then the other piece is also up like this, but more as a way to engage and escape so that I can run away. That's my flight. The parasympathetic part of the system is the rest and digest phase. This is where I'm slowing down and conserving energy, and it's also where I'm processing through my trauma. So when we have our stress hormone continuing to go up and continuing to get activated, what we need is the parasympathetic rest to come in and be able to have a cycle instead of continuing to go up nonstop. And then the next part that I'm going to talk about in a moment after ventral vagal is freeze. So the ventral vagal complex, when we talk about fight and flight, is kind of what I was talking about. So I noticed that, like, for example, my chest is up, my shoulders are back, and I'm ready to do something. And so the ventral vagal part of the nervous system is the front part of the system, meaning that it's engaged when I'm like this. And so it's feeling that protection, that frontal protection. It's if I perceive a threat is happening. So we did talk about earlier, like if I do perceive a threat and there's no threat there, I can be stuck in fight and or flight response even if a threat's not there. So I can be angry all the time, or I can be fearful or anxious all the time, even if a threat is gone. I might have physical reactions to certain things that come up. I might be really jumpy if there's a loud sound out of a flight response, or I might just be one of those really loud yell-talking people because of the anger that's trapped in my system, and I may not even notice it. Social engagement is also another part of ventral vagal complex, meaning that, and I'm going to talk more about it in a bit, but that's where we want to be. So ventral vagal fight and flight is not just all bad, but ventral vagal also means social engagement. So if I'm not in fight, flight, or freeze, I'm in social engagement, and that's when secure relationships and secure attachments are happening. The dorsal vagal freeze complex, this is a continuum of behaviors, or we can say it's a, oh goodness, spectrum. There it is, the spectrum of behavior. And so on one side of the spectrum, you'll have very low level dissociation. And an example of that might be, it might be that if that's an example. So if I'm getting stuck off into nowhere for a moment, that's what it can look like. Another example is if I were to ask somebody, hey, have you seen my glasses? And they're right here on my head, even though I just put them up there, that's another low level dissociation. And guess what? We all do it. It doesn't mean we have trauma. It just means that we have some freeze on board, and that's totally healthy. As we go up the spectrum, we get to places where, let's say, for example, somebody feels like they're losing track of time. Like maybe they look at the clock one moment, it's 2 o'clock, and then the next time they look at it, it's 6:30, and they're like, hey, where did the last 4.5 hours go? That's kind of a level of dissociation. Another part in this play is for people who play video games a lot. It's kind of a dissociative tool, and then also for people who binge Netflix or Hulu or whatever your Disney Plus, whatever your digital video of choice is, they're kind of a little up higher on that continuum of behaviors, and it's more normal than the much higher things, but also it is dissociative, and it is a tool to be able to help take care of yourself in a freezy kind of way. And as we get up higher, this is where people start to lose track of days. They might lose track of, projects they were doing at work, or they may actually start to lose gears as we get higher up. I've worked with a lot of people, and maybe you have too, who have said, oh, I don't remember anything that happened in my life between ages 5 and 8. And that's an interesting thing to remember, that you don't remember anything during that time, but that means that freeze was very active and it prevented the creation of new memories. And so as we get higher up on the continuum, that's when we look at things such as people who have dissociative disorders, dissociative identity disorders, where they kind of move in and out of different personalities in order to protect themselves. And then we have the kind of the highest on the spectrum, which is for those who, let's say, for example, are catatonic. And so they're the ones who are hospitalized or they're comatose, and there's not really much else they can do. And one of the examples I use is I was reading this article several years ago where this woman had, she was a nurse, I believe, and she worked overnights. And one night she came home from work, or one early morning she came home from work and went to sleep. And then when she got up in the evening to go to work, she had a brand new vehicle in her garage that she bought while she was asleep. And so she didn't remember, sleepwalking is a form of this, but she didn't remember buying this car, but all of the information was in her signature and her handwriting. And so she really dissociatively bought a new vehicle. And so it was really surprising and scary for her. Oh, and then freeze comes online when fight and flight are not achievable. And so if I cannot fight or I cannot flee, fight or flight, and if I'm not in social engagement and I cannot fight or flight, I will freeze. I will shut down. There are also people who have experienced freeze as a form of depression. And so for people who are stuck in bed all the time, it's usually because freeze is very active in their system. And one of the main things you tell someone who is in a state of depression or in bed all the time is you tell them to go do something. You ask them to go to the gym, get out of bed, go take the dog for a walk or something like that. And once they start to move, they're like, oh, I feel better as they start to move. And that's because they're taking the system that's shut down and they're bringing it back up in order to help activate that sympathetic arousal. Because you have someone who's stuck in parasympathetic all the time, they will have more of that activation that needs to come in order to heal it. Trauma can look like a lot of different things, and I don't necessarily want to read all of these. You can read them if you'd like, but it's just really how people can see how their trauma presents in different ways. And some people may say, oh, I don't have trauma because I don't have flashbacks or I don't have nightmares. But that's not necessarily all trauma symptoms look like. It looks like a lot of different things. It could be things such as, self-destructive behavior, or maybe there's an eating disorder, not having memories, as we talked about. So it can look like a lot of different different things. And so you might be able to even say, oh, hey, trauma has also looked like this for a client of mine, or hey, this is what trauma has looked like for me over the years. And also trauma can present in other ways, such as perfectionism and high success. For people who have high success for things, or a lot of perfectionism, that's a way trauma can present. So trauma doesn't always have negative, I mean, it might be negative, but it doesn't always mean that it's bad. Some people can be able to get more of a drive if they have trauma. Physiological signs of a threat response. This goes back to our fight, flight, and freeze as we were discussing. And so you can actually look at some of these and just ask, is that a fight response? Is that flight, or is that freeze? And see what your thoughts are about it. Some of these, actually many of these, are a multitude. They're kind of a combination of fight and flight, and or fight and flight and freeze. Because what happens with freeze is that our system gets stuck with, let's say, for example, a fight response. And so I might be stuck in an angry place all the time because of my fight response. I want to take a moment and invite you to check this out. See what the image looks like to you. I know some people have liked this image. And just FYI, all the images I picked I really liked. But some people like this image and some people don't. And it's okay if you don't like it. If you don't, you can just look at another place in your room. But allowing yourself to recognize how you feel inside when you see this. Maybe you imagine yourself in the image, curled up under the book, or under the tree with a book. Or maybe you're taking a nap up in the tree. So allowing yourself to orient to that surrounding. And then see what happens inside. Perhaps you're noticing sensations, maybe something that feels light and airy in your chest. Maybe there's a pain in your low back. Maybe there's heaviness in your feet, like a good heaviness. Might also be a bad heaviness, but just being able to feel that groundedness. One of the things we're doing today is we're doing a lot of work with the body. And then what we're also doing is we're recognizing that we can see our responses and how it's going to be different for us. And while we're not there to be able to talk to one another and see what our differences are, I assure you that there have been differences. We're also talking about attachment systems, and when we do that, it can be activating for people who have not had a lot of secure attachment. And so I just wanted to name that if you feel like attachment is difficult for you to kind of hold on to or recognize inside your own system, that's okay, and it's not outside of the norm. There are a lot of people who are able to have healthy and secure attachment relationships as adults that they couldn't have with their parents when they were children. And that experience is okay. So the window of tolerance, you may have seen this before, but it basically gives us the idea that our system has different ways of looking that it can take care of itself. So the top one is resilient nervous system, and this is where social engagement is present. Fight and flight and freeze are coming as healthy responses. People are really kind of feeling those secure attached relationships. Things might be difficult sometimes as it kind of goes up, but it's everything within the tolerance level of what someone can do. You do have the sympathetic charge and the parasympathetic deactivation, and so that constitutes a cycle, and they can do all of that within their resilient nervous system. The overactivated or dysregulated nervous system this has people who are all over the place. And so, and like you could see at the beginning, it's kind of like, looks like a roller coaster, just like going up and down. And what I like to see, and I'm not sure if you can see my mouse arrow, but I'll do this here. But what I could see is as it goes up here in the beginning, it goes over the window of tolerance. And once it goes over the window of tolerance, that's where freeze comes into play. And so it might be a freeze and a rage, or a freeze and a flight, and that can look like anger, or it can look like a fear or anxiety. And then let's say, for example, somebody's up here and then they say, oh, I'm feeling too activated. I need to do something such as drink or use substances. And so then they bring themselves down to about right here. And this is the part where they're like, oh yeah, hey, I feel chill. I feel like myself again. I'm good. But then they keep using and they end up down here. And this is like the frozen depression place. And so then they're going to sober up and feel better and start following things as they were before. And then they do this, and they get up higher this time, and then they do the same thing again and go back down. And so they just kind of do this back and forth zigzag of I'm frozen in anger, or I'm frozen in depression, or I'm just going back and forth. And then you have the people who are stuck on. These are the people who remain in an anxious, activated, or angry state. And so what we need to do for these people is bring in more parasympathetic rest in order to get to this place up here. And so as we bring this down, somebody might be stuck off, and so they spend time in a depressed state, and then they finally go back up. What you might see, you see over here, elation and mania. Oftentimes, bipolar disorder gets misdiagnosed when it's actually trauma symptoms. It doesn't mean bipolar disorder doesn't exist, because it does, but there are a lot of people who actually have the manic type behaviors followed by the depressive type episodes, and yet it's not enough to constitute bipolar disorder. And so what we're looking at is being able to help the system figure out what it needs to do in order to get to this place. Meaning that if we get out of our own way, our system's going to be able to take care of itself. And then I ask, what do you see here? How does that feel to you? Does this look like a healthy relationship? Does it look like they're having fun? I think it does. And if you see that and think that they don't, that's also okay. The last time I presented this, I'd asked the question, does it look like they're having fun? And someone in the crowd said, I'm afraid to answer because of the thing that happened with the other picture. And I mean, yeah, it is okay to see healthfulness in it. And it's okay if you don't too. And then we have the ventral vagal part of our nervous system, our social engagement piece. This is where we're having healthy interactions and nourishing relationships with others. We're having fun. And what we also notice is that our facial features will soften or change. And so our healthy attachment can kick in. And so we get to see how connected we are with others. Right now and over the last 8 months, it's been really interesting because we haven't really been able to connect with each other with our whole faces. And so if I have this mask on that's blocking half my face, you can only see some of what my expression is. I mean, I'm a very expressive person, so you can usually see most of my face, and if I'm talking with my hands, so I usually get my message across. But what we notice is you can't really see this part of the face. And so if I cannot be seen, if I'm walking in the store, I might smile at someone, and it also might look like I'm scowling, or it could look like I'm giving them a look or something. And so what we want to be aware of is that there are ways of engaging with other people, like saying things like, hello, how are you? Instead of just doing that, the wincey smile that they think might be something that's threatening for them. But if you see my face and you can see more of what happens as I talk and as things move around, you get to see how much more engaging it is to have that connection with someone. For somebody who has a lot of trauma, you'll notice that you'll see that their face doesn't move a lot. So they might be like this and might be talking like this, and maybe they're not really moving their eyes much, and maybe they're not really making much sense, or they're talking monotone. That's what freeze can look like in the face. And if you have somebody who's expressive and has has healthy attachment and has been able to make these connections with other people, you get to see how much more liveliness is in the face. It's like the face and the body, of course, unfreeze out of that frozen block of monotoneness, and it comes back to life. I know a therapist who encourages people that he works with in private practice to take a picture on the very first session, or he has them take a selfie of themselves on their very first session, and then after doing some work with them for a while, we'll have them take another picture and notice the difference in the facial expressions, and notice how much more the face looks connected than it did prior to doing that work together. The social engagement part is where we want to be in our relationships. We want to be connected in that way. And then I ask you to see what you see here. If I were to tell you, in 10 minutes a tiger will come into your room, you have a chance to plan. You have a chance to have an escape route, hopefully, or get out of there so that in that 10 minutes when that tiger arrives, you'll be long gone. Or I could say to you, nothing, and the tiger just appears. And then you'd notice what happens inside your nervous system. It could be fight response, it could be flight response, and it could be freeze. So one of those three responses may come up. I'm hoping no one wants to fight the tiger, because that doesn't sound very winnable. And then flight is definitely preferred, but also freeze may come online too. Someone might be too scared, meaning that their nervous system can't tolerate that level of fight or flight, and so they will shut down. And everyone is different, will have those different kinds of responses. The naturalistic approach is one of my favorite things to talk about, because it discusses the animals in the wild and kind of what things look like when you compare wild animals to humans. Animals have a natural immunity to having experience or having a reaction to trauma. And so what we notice is humans actually have the capability of, let's say, for example, to stop by the bar after work to have a few drinks before going home, to be able to bring that system, as we think it does, back down here. Animals don't get the opportunity to do that. Animals are social engaging, or they're fight, flight, and freezing. They're not doing anything in between that, because they can't. They're not trained that way. We as human beings get in the way of it. What we notice is there's actually some videos out there of prey animals such as gazelle or deer being chased by a predator, and one of the prey animals actually gets attacked. The animal survives, but gets attacked, and it freezes so much that the predator thinks it's dead. Well, then another animal comes, I think it's a baboon, another animal comes over and scares the predator away, and then that deer actually gets up and runs off, and then as soon as it's in a place where it's safe, it lies down and it shakes all the trauma out. One of the things you may notice is if you're driving and somebody pulls out in front of you, and you slam on your brakes and you maybe say some choice words to them, after that, you might notice something in your body. And one of the things that I notice, at least for me, and I've heard others say the same thing, if my hand's on the steering wheel, I'll notice some shaking. My hands will start shaking, and my body will kind of feel a little bit of tremoring, because that thing where I slammed on my brakes and thought I was going to hit this person, that was a trauma that happened inside my body. And so if I allow myself to just sit with it and let the trauma move through my body, it will shake its way out, and I could be done with it after that. Many people, though, humans especially, will actually totally avoid that and will, for example, grab the steering wheel tighter and say, nope, I got stuff to do. I need to go to work, or I need to go, shopping, or whatever it is. And they hold on to it. They don't let that feeling process or that trauma process through the body. And that's where it gets stuck. That's where we start building those things that we shouldn't be holding on to because we get in the way. And we as humans have the ability to get in the way. And so it's much harder to say, okay, yes, I'm just going to process through my trauma right now. And that's why it can take years for some people to move through a lot of their things because of that response that they come up with. Nature has instilled in all animals, including humans, a nervous system capable of restoring equilibrium. So my nervous system can restore itself to full health if I let it, and if I get out of the way enough to be able to allow it to do what it's there to do. Healing can look like a lot of different things and feel like a lot of different things too. And we did talk about the trembling or the shaking. That's a physiological sign of healing. Other examples are expanding or lengthening. A lot of times people will say within their body, they're like, oh, I feel my chest opening up. And people might notice warmth, feeling more calm or more soothed, feeling being more present. People who are stuck in freeze tend to not be present, and so once people come out of freeze, they start to feel more of being available. Feeling of fluidity or energy, having lightness, doing deep breaths, and just feeling like you're at your center. That's what healing can look like. And the signs of healing: improvement in quality of life and day-to-day functioning, reduction of core symptoms of intrusive re-experiencing, numbing and hyperarousal, and then improvement in self-regulation in the domains of emotional regulation, relational capacities, dissociation, adversely affected belief systems, and somatic distress. And so if you're feeling better, you're getting better. And so that's a sign of healing, of being able to notice that you're not necessarily dissociating, and you're not having unhealthy relationships, and you're having more secure attachment with those around you. And so I'm going to ask you all to join me in a somatic mindfulness meditation. And again, this is optional. You do not have to. But I'm going to do this with you in order to help notice, because I know as I present this information, typically we'll start with info and we'll orient and then start and orient, and it can be a little difficult to stay in a grounded way. And so my intention is going to be, as we're coming towards the end, to be able to help you find a way of grounding. And maybe this is something that you can use with your clients that you work with. And then also afterwards, we'll open it up for questions and be able to have more of a discussion about it. So again, this is optional, and so if you do not want to, you do not have to, and yet I invite you if you want to. So first, by allowing yourself to feel where you're at, whether you're sitting in a chair, you're lying down, or maybe you're on the floor, who knows. Wherever you are, just allow yourself to feel that sensation of maybe the chair holding you up, maybe your feet on the ground, or maybe your head on a pillow if you're lying down. And sometimes this actually encourages people to go ahead and lie down, and so if you want to do that, that's actually great too. And then you get to decide whether or not you close your eyes or keep your eyes open. There's really no mandatory way of doing this, and every way you do it will be just fine, and there's no wrong way to do it. So as we're going in, allow yourself to notice just overall how your body feels and what's going on inside. You might feel warm, it might feel tingly, it might feel cold. Don't know where you are weather-wise. It's a little warm in the desert now, but allowing yourself to just feel what it's like to just be in the body. And then as you notice that, find your feet. Allow yourself to notice your feet on the ground or wherever they are, and see if you can imagine them touching the earth, even if they're not touching the earth, and if they are, imagine the earth rooting itself up into your feet or around your feet, whatever feels best for you. Establishing a sense of groundedness and openness. You can move up into your ankles and breathe, noticing the sensation of what happens in the body when you do that. Continue to move up into the calves. And maybe you notice there might be a little pain, or maybe there's comfort, safety. And as you continue moving up into the thighs and pelvis area, and just seeing what that feels like where you're at. I also invite you to see if you want to design the energy. Like as the energy moves up, does it have a color, a texture? Is it like a light? Is it like a fluid? What is it that makes it comfortable for you? As we continue to go up into the abdomen and low back, ask yourself how this feels. See if there's anything in your core that needs attention. This is often where people might notice low back pain, or maybe the relief of low back pain. Taking a deep breath as we move up into the chest and upper back. You might even want to kind of push your shoulders back a little bit if they're hunched over. Sometimes posture can be difficult, and so being able to organize your posture. As we move up into the shoulders, we'll go down the upper arms and the forearms and into the hands. At this point, don't forget your toes are there. Wiggle your toes a little bit, and then also wiggle your fingers. See what it feels like to feel connected from your toes down to your feet. Your toes up to your hands. There we go. And just see what that connection is like. As we move up into the neck and head area, see if you notice what's going on in your throat. We've moved past all the other organs. And then move into your head. And this is where you have the opportunity to explore quite a lot. This is where you can connect to your orientation senses by either smelling what's going on or smelling what's around. Maybe you have your hand on a pet, or maybe you have your hand on something that's soft and comfortable. Maybe you're laying on your favorite blanket or couch or bed and just feeling that relaxation. Yawning is a sign of parasympathetic rest. So if you're yawning in this process, that's a good thing. And the goal of what we're doing is to help bring more parasympathetic rest. Not assuming that you haven't had parasympathetic rest, but just to give you an idea of what this looks like. And now as we've been through the whole body, just take a moment and feel the energy surge. And it could be a slow surge, it could be a fast surge, whatever surge feels more comfortable for you. Just feeling that connectivity. And then checking with your whole body, seeing if there's anything that needs attention, seeing if there's pain or pleasure. I hope you're yawning too. Could be because yawns are contagious, or it could be because of parasympathetic rest. And now at this point, feel your hair or your scalp in case you don't have hair. And just see what that's like on your head. Notice your eyebrows and your ears, your nose, mouth, and then your chin, just kind of your whole face. See what that feels like. Does it feel like it's tight? Does it feel like it's soft or has softened? Is there enough movement in it? Do you feel like the freeze is there, or does it feel like it's been thawed out? Or maybe it was never frozen in the first place. Move down into the neck. Maybe with another yawn. And just see what it's like there. Sometimes when people are here, they like to move their neck around to do a little bit of stretching and have some comfort there. And then we move down into the shoulders, down the arms, into the hands. And then wiggle your fingers and toes again. Maybe at this point you might be feeling some energy in your body. It might feel like it's coming down your leg or coming down your arms, and that's okay. Sometimes when we do this work, we feel the energy actually come out of our extremities. And so it can be movement, and that's something that's totally normal and okay in this process. Let's move down into the chest and upper back and see how we're doing there. And down into the abdomen and low back again, hoping that pain that might have been there the first time around is gone. And it's okay if it's not. I want to say also, I don't think I've ever yawned this much in doing this before, so I think I really needed this, and I hope this is benefiting y'all as well. Continue moving down into the pelvis and thighs. And just see if you feel comfortable. We continue down through the knees and calves. And then ankles and feet. And as we're at the bottom of the feet, allow yourself to feel the energy of the roots. And recognize that it wasn't the roots that gave you this energy. You are giving energy to the roots. You are creating this dynamic for your surroundings. You have the power to be able to move through whatever it is you need to move through. And that strong ground is definitely needed. At this point, I'd like to invite you, if your eyes are still closed, to keep them closed. And if they're open and you want to close them, you may, and you don't have to. And I want you to imagine your tribe again. Maybe as we've done this presentation, you probably notice more people in your tribe, or perhaps maybe even less people in your tribe as we've gone along. But see your tribe. See those people and know that they do anything for you that you needed. And that they really care about you. And then instead of just imagining one pair of kind eyes, imagine all of them. Your whole tribe giving you kind eyes. Letting you know that you're safe. Letting you know that you're loved. And see what that feels like inside your body. Take a deep breath. And see what happens when you release it. Do a scan of your whole body. And ask yourself what you need. Is there an immediate need that you can meet right away? Is there an eventual need you have that you may need to schedule something? I personally recommend acupuncture or massage. You deserve to take care of yourself. And while COVID has been very challenging, we can still take care of ourselves during this time. And I ask you to reflect on what it's been like to be in my care for the last hour and a half plus. Ask yourself what it's been like. And see if it's something that's felt good to you. And recognize that we heal together. These wounds that have been created, whether they're relational wounds or trauma wounds, we heal. I'm very grateful that you all were here today. I will be moving to the questions portion. And so please, if I understand how this works correctly, I'm sure I'll get some help from Courtney if not. I will, just a second. Aha, here we go. Let's see. Oh, I see a congratulations. Thank you. I appreciate it. I'm not going to say your name, but I remember you too. Okay, question. What about a cancer diagnosis? What kind of trauma is that? So a cancer diagnosis is considered to me chronic illness, chronic medical illness. And so that diagnosis is definitely considered or can be considered a complex trauma, and it can definitely be a single incident trauma as well. Sometimes people have, a mild diagnosis and it gets treated very quickly and they don't have a lot of impact from it. Other people might have a lot of recurring things that happen, and so they don't really experience a lot of remission, and so it can keep coming back to traumatize. And then for people who are children or in their developmental phases who get a cancer diagnosis, that becomes developmental trauma, and so there's a whole tie around it. And interestingly enough, it kind of hits all of the trauma spectrum, because it also can be intergenerational, as they know, or they're learning that cancer, or they have been learning that cancer can be genetic, and so if there's a genetic disposition, that can be handed over time. So it's not necessarily the trauma feelings that happen with it, but the medical disposition can create that as well. But I would say it's all across the board depending on the type of cancer. Oh, okay. Thank you. I was also told to keep my hands out of my pockets as a child too, as they are Asian. I think that example crosses the BIPOC line. It absolutely does, and thank you for saying that. And I will definitely make sure to utilize that as not just happening in the Black community, but across all communities. Someone said, definitely safer and peace, feeling loved. I'm glad. What is the ratio of people with PTSD who may present with multiple personalities? So dissociative identity disorder, or also called DID, used to be called many years ago multiple personality disorder. DID is pretty rare. And so as far as a ratio, I'm not really sure, but it's not a common diagnosis. And it's something where everyone is different. Some people will actually experience, a couple personalities, and then other people might experience a lot of different personalities. And there's not very much information out there about ratios and statistics for DID, but I would say that it's not a common occurrence for people to experience. We do work with some people here at Sierra Tucson and have over the years with DID, and yet it's not something that I see as being really common or having a high ratio. And someone said, peacefully going on a hike, mentally, yeah, it seems like a lot of chronic illnesses can mimic trauma responses and or the other way around. How do these interact with each other? That's a really good question. And so chronic illnesses mimicking trauma, I think an example of this, and one of the things that I think of quite often when this comes up, is for people who have the things that we were talking about, like borderline personality, maladaptive traits. And so those people, as some people might see them, they say, hey, that person is just trying to get attention, or, oh, it's just their borderline, or, oh, they don't really mean they're going to harm themselves. They're just trying to, rile everyone up. And really what that is it's a trauma response, but it's also a chronic illness. And so they actually go, chronic illnesses and trauma responses actually go hand in hand quite a lot. Even for people who, let's say for people who have chronic pain management issues, they might feel like they need to manipulate their providers in order to get more medications, et cetera. Or maybe they're trying to see multiple different providers. Let's see. Someone smiling big with their eyes. Yeah, when I smile really big, my eyes kind of squint a little bit, so I don't get like the full like big smile, but definitely. What if a person can't imagine or visualize people in their tribe? This actually does happen quite a bit with people who have a severe trauma. And it's something that I will talk about and bring up. Like when we were talking about kind eyes, and if somebody can't imagine a person, they might imagine a dog, and that's what really helps them feel safe and comfortable. And so for people who may not be able to visualize anyone in their tribe, maybe they imagine pets, and it could be a present pet that they have or a pet in the past. It might also be, and this is something that can be cause for creativity, maybe there's somebody who's found their comfort and solace in something like movies or books or video games. They can imagine seeing those characters. And so for people who haven't really had any healthy connections, they can imagine fictitious characters that mean something to them, and that can be their source of their tribe. And let's see. For clients who are not on board with breathing and being in their body yet, what are some ways to begin to teach them ways of being with the body? That's a really good question, because oftentimes, especially people who have a lot of trauma, they are not familiar with their bodies. They might think they are. I've known a lot of people who've been doing yoga for decades and are yoga instructors, but they have no idea what's going on with their body. So we don't want to force anyone to. That's why everything I do when I present and when I do work with people, everything is invitational. It's an invite to say, if you're willing to do this, you may, and if you don't want to, then that's totally fine. Because if you say to somebody, hey, take a deep breath right now, they might meet with resistance and be like, no, I don't want to do that. Or if you tell someone, hey, go inside your body and tell me what's happening, then there might be a reaction there, or they might not even be able to feel what's happening in their body. And so to be able to create everything by invitation, you're going to learn a lot for what people can deal with and what they can't. And so if I say to someone, hey, take a deep breath right now, or in a more invitational way, hey, would you like to take a breath right now, asking the question, they could say no. Well, then I know that I can try something different. One of the people that I have trained with had said, what do you say when you bump up against someone's defenses? You say, excuse me. So if you say something to someone and it doesn't quite land or it doesn't quite fit, you can say, oh, my bad, I'm going to move on to this next piece. or let's try something different, a different approach. So yeah, absolutely. There are going to be people that it doesn't land with and it doesn't connect with, and that's totally okay. There's other ways around it and other things to practice. Let's see. What measurement tools do you use to assess a patient's trauma? One of the most common tools to use to assess trauma is the ACE, Adverse Childhood Experiences, and that's the survey that's going to be able to give you a whole lot of information about how much trauma a person has gone through or experienced. That's the one that I've used the most. How can you determine whether trauma has been resolved versus suppressed? That's a really good question because you can't always tell. One of the ways to tell is to be able to talk with a person and see kind of what their reactivity is, because they may say, I've worked many times with people who said, oh yeah, I processed that in EMDR 10 years ago, and yet a trigger will set them off and they'll be dysregulated for days afterward. And so it's really hard to tell whether or not something's been fully processed. And yet time tells based on how much work that they've done, but also their reaction to it is going to be a real indicator of whether or not they've processed through it completely. Could you say a bit about the attachment wound / trauma of early parental loss, whether through death or infant adoption? Yeah, so attachment wounds and trauma of early parental loss through early parent death or through adoption, it's real severe, just because needing that close love and affection with that primary caregiver or those primary caregivers is crucial to development. And so for losing that connection, there's going to be probably sometimes even months in between with a rift. Maybe the person is in child protective services or foster care and they're not able to get connected to a healthy family in a reasonable amount of time. And so what that would look like would be needing to have that close connectivity with others. And sometimes that doesn't happen right away. I've worked with someone who actually teaches about attachment trauma, and she had said that when she was very young, she had to be in the incubator for several months, and so she lost out on the first few months of healthy attachment. And even though she had a very healthy connection with her parents, it kind of created more of an anxious attachment style for her because of not having that connection in the very beginning. So it can definitely create that adverse experience. Let's see. Just a second. What books, trainings, or other resources do you recommend to deepen this learning? One of my favorite books to read about this is The Body Keeps the Score by Bessel van der Kolk. He talks a lot about what the trauma looks like within the nervous system. There's also the Waking the Tiger by Peter Levine, who's the creator and founder of Somatic Experiencing. And so those are two books that would be really good resources. There's a lot of resources out there, but those are the two that I usually recommend first. And then other trainings to deepen this learning. So the DARE training that's hosted by Allison Hallquist, Daniel Vose, or Diane Pull-Heller. It's DARE, and you could just Google, I believe it's DianePullHeller.org, and that's Diane, DIANNE, Pull, POOL, Heller, HELLER, I think .com, I believe is what that website is, and that would give you more information about the DARE trainings. And then, of course, the other training, the Somatic Experiencing Practitioner training through the Trauma Healing Institute, or Somatic Experiencing Institute, and that's traumahealing.org is the website for that. And then do you think you can be stuck in fight, flight, and freeze at the same time? Yes, absolutely you can. And the reason I believe so is because we see it in almost every single one of our residents that comes into treatment here, because you've got the people who come in and they have this shutdown, or maybe they're depressed, but also as soon as they come out of that depression, they're angry, or they're really afraid. And so it's kind of the sense of like taking that anger or that fear and just putting it in a big block of ice. And then once people start working on it, it starts to melt, and then they come out into this rageful, panicked state. And I've been framing COVID anxieties as a form of chronic trauma insofar as a constant state of hyperarousal, scanning for threats and re-equilibrating, seeking safety. What parts of this framework am I forgetting to incorporate in regards to attachments feeling far away and attachment security? Think about that one for a second. So, yeah, COVID anxieties, it's really, really big because it is chronic trauma. Being in that state of hyperarousal, especially for, and I know earlier I used the grocery store reference earlier. Sorry, I had a visitor. I used the grocery store example earlier, and that if somebody's right behind me, I'm going to be hyper aware of that, not just because of my bubble and the trauma response, but also because of the COVID piece. Like if this person is really close to me and maybe they're wearing their mask like this, like a lot of people are doing, that's going to be a source of fear for me, and I'm going to have this threat response, absolutely. And I don't think there's any part of the framework that you're forgetting to incorporate, at least it sounds like, except for just kind of being aware of your surroundings and that scanning for threats. And this hyperarousal scanning for threats to me does not sound so much like a trauma response, but more like an appropriate way to respond in this current state of how things are. And then, of course, if you want to continue discussing that, you can contact me by email, and my email is david.cato@sierratucson.com. A lot of these questions have several parts to them, so I'm trying to kind of field them out. Do varying attachment styles associated with varying attachment do varying attachment styles associate with varying trauma responses? Yeah, they can. For example, I know we use the example of somebody who, for example, over the first 3 months of their life are incubated, they might have a more anxious type of response because they need that more connectivity to their parents and their loved ones. And so that could be an example of what that would look like. So somebody with a more anxious attachment style might be someone with early life attachment disconnect, and not even because of anything in particular. Oh. Let's see. Okay. This is such a bizarre question, but because yawning is a parasympathetic response, do you think that yawning is contagious because we can actually let our guard down since the other person yawning is not in fight mode? You know what? I really love this question, and it's so funny because during my somatic experiencing training, what I noticed, it was probably like the second year, I noticed like as I was entering parasympathetic, there was a lot of yawning happening, and I noticed that other people were doing it too. And so that's kind of the situation the solution we came to as a group of people is, hey, I'm feeling more relaxed and more calm, and so I'm yawning. It's parasympathetic. And so it was just kind of like how this all relation came together. And so my theory about yawning being contagious is not so much about being vulnerable, or letting our guard down, but it's more about mirror neurons. And so our nervous systems actually impact other people's nervous systems. And so the reason we as therapists or as practitioners can actually sit with people and help them feel better just by being in their presence is because our nervous system is bouncing off of theirs. And so the way that I would answer your question, I think, and again, you can email me if it's out of left field, is that we're actually mirroring the neurons and we're helping that other person have a parasympathetic response. I will also say when I'm talking on the phone with my partner, what I notice sometimes is like after a long day of us both being at work, what I'll notice is we'll both start yawning, and I hadn't yawned all day, and so we just kind of talk about that being a parasympathetic response of, oh, I know what that feels like. We're just kind of we're helping each other co-regulate in that way. See. These are a lot of good questions, y'all.
David, we have time for about one more question.
Okay, all right. Okay, I'm going to end with this question. Someone said, I was diagnosed with stage 4 lung cancer, but I don't feel trauma. I've been in remission a little over 2 years. And so this is a really big, important piece because there are traumatic things that happen to a lot of people pretty much every day. And just because something is perceived as a traumatic event to some person doesn't necessarily mean that another person would feel trauma. When we had talked about the predictors for trauma, about the magnitude of exposure, prior trauma, and the social support system, people who don't have a lot of prior trauma and who don't have a big exposure and also have a really strong support system or have had a strong support system, their nervous system is more likely to not develop trauma or PTSD after what could be perceived as a traumatic event. And so I want to say, I'm really glad and congratulations that you've been in remission over 2 years. It's a beautiful thing to see people who can survive cancer, and you're really brave, and you're really you're very encouraging for me and even a lot of people, I'm sure. And I want to say that you don't have to feel trauma from that. I think that if you feel strength with that and it feels okay to you now to be in this survivor place, that strength is what's going to help you. That strength is what's going to help you build resilience with other people. And it's going to help other people have that resilience as well for you being able to carry that through. And I just really, your story is invigorating to me. And I'd like to talk to you more about it, but I'm really glad you shared that. Thank you. And no, you don't have to feel traumatized over something like that. And I think that's all the time we have.
Thank you so much, David, for an incredible presentation, and thank you everyone for joining us.
Thank you.